that the LBJ School and the Teresa Lozano Long Institute of Latin American Studies has a long trajectory of collaboration. And we are very happy to continue this collaboration with such an important event. And Carlos Moreno, who is a visiting researcher professor at the LBJ School with a Fulbright program, has made this possible, as well with Paloma Diaz, Assistant Director of the Institute. I am very happy to introduce Dr. Frenk. Julio José Frenk Mora is the president of the University of Miami since 2015. And I have to say that he's the first Hispanic, native Spanish-speaking scholar, intellectual to serve in this role at the University of Miami. Prior to that, he held several important positions, including Dean of the Harvard T.H School of Public Health, and he was also the Secretary of Health in Mexico from 2002 until 2006. So his vast experience in this in health-related issues is very huge. Today, he will be talking about the challenges for universal healthcare protection in Mexico. And thank you so much, Carlos, for making this collaboration possible. And thank you, Dr. Frenk, to be here with us today.
Thank you, Adela. And just let me say it again that the work of Dr. Frenk has been inspiring for my own research work in the last 6-7 years. And well, the floor is yours, Dr. Frenk. Thank you for being here.
Well, thank you very much. Good morning to everyone. Thank you, Dr. Pineda and Dr. Moreno, and thank you to Paloma Diaz for allowing me to participate in this dialogue. I'm also, I understand that Professor Jacqueline Angel is there, who's been a colleague for a long period of time. And it's just a great pleasure for me to, once again, because it's not the first time that I've spoken at the University of Texas at Austin, to be able to speak about health policy in Mexico. What I'm going to do is share a basic presentation to set some of the elements. It's a very brief overview of what's been going on in the recent years since the beginning of the 21st century with health policy in Mexico. Professor Carlos Moreno has been a great scholar of the reforms in Mexico, which many of which I had the great honor of designing and implementing during the 6 years I served as Secretary of Health from the year 2000 to 2006. And I'm going to share my screen, but I'm mostly looking forward to the dialogue afterwards. So I'll keep my remarks at a high level of generality, and if there are questions, I'll be happy to give a little bit more detail. I have, let me quickly do this. Okay, I hope you can all see the screen appropriately. So Professor Moreno wanted to link particularly the reforms that led to the program called Seguro Popular with our efforts to address social inequality, using health system reform as an instrument to deal with what's been the underlying, probably most pervasive problem of social policy in Mexico historically, which is social inequality. And I'm going to pretty much try to leave you with this key message. And it's basically that in almost the first 2 decades of the century, from 2000 to 2018, Mexico actually made substantial progress in addressing, not completely solving, but at least made progress in addressing the secular problems of its health system. And therefore, as has been documented with a lot of empirical research, the general level of health of the population improved. But also, and very importantly for the issue of social inequality, social disparities were actually narrowed. Access to care was expanded and catastrophic expenses were reduced. Now, in 2018, Mexico had a very important election, which led to the current administration. And at that point, the country was really ready to take the next big step towards developing a universal health system. However, what we have seen these last few years is really a regression to some of the, what I will call and explain the concept, what is a corporativist model that really was characteristic of the 1970s, of the 70s of the last century. So to elaborate on this message, I'm going to basically touch four topics. First, give you an overview of what happened in those 18 years. As many of you may know, Mexico has 6-year presidential terms. There's no re-election of the president. So that's why the 18, it's 3 administrations. Then I will talk about what the current administration has done, basically in terms of some of the regressions that we have experienced. And I will use the term 4T because the current administration labels itself as the 4th transformation in the history of Mexico, and it's popularly known as the 4T. But I want to look forward, not just backwards, and not just to the current moment, and see how Mexico should actually develop a new generation of reforms, and then just very briefly touch on what would be the immediate steps. But let me start with the first topic. At the turn of the 20th to the 21st century, there was a very substantial problem, which was documented thanks to very extensive studies. I myself carried some of those studies. I have to say that I ended up being appointed in the year 2000 as Secretary of Health without really being a politician. I did not, and did not at that time, and not even to this day, belong to any political party. But as many of you are aware, in 2000, Mexico had a historic election, the first fully democratic election, when a party different than the one that had won every presidential election in the previous 72 years, a different party won the election. And that sort of litmus test of democracy, which is the possibility of alternating, party alternation in the executive power, finally became realized in 2000. The new government, which was led by President Vicente Fox, was looking for new faces to form the cabinet. And they thought that at least for cabinet positions that have a strong technical component, a technical substratum, like as is the case of the Ministry of Health or the Department of Health, that it was important to bring in experts, not billionaires into the cabinet, but experts. I was at that point working at the World Health Organization in Geneva, Switzerland, and I returned to Mexico. I stepped down from my position at the World Health Organization and had this great honor. Because of studies I have been doing, and which I will not summarize, we had identified that about half of the population in Mexico in 2000, first of all, were suffering from a growing burden of chronic non-communicable diseases like heart disease, cancer, diabetes, mental health issues, problems that were much more expensive and complex to deal with than the more common infections that had been the main problem of poor people in the past. There's still a disproportionate amount of those infectious diseases and maternal deaths among the poor. But the poor were also suffering more and more than the non-poor from this sort of chronic non-communicable disease, as I just mentioned. And because of that, which has been called the epidemiologic transition, that different epidemiologic profile compounded with a lack of insurance for about half of the population. And the consequence of that mix was not only delayed care, but also catastrophic expenses. I have to tell you that what I am going to narrate here, this reform that happened in the early part of the 21st century, probably one of the most widely studied reforms. There's a vast literature. There's probably at this point about 150 peer-reviewed papers. And so I'm not going to go into any of the detail because anyone who wants to have more information, there's really a very large literature to draw upon. But let me just show you this issue of catastrophic expenditures. So through the work mostly of Professor Feliciano and other economists, it was possible to quantify for the first time catastrophic or an impoverishing. There's a small, but not a small, actually it's important, but a subtle distinction between those two concepts. Catastrophic expenditures happen when a household spends more than a certain threshold, typically it's set at 30% of its income on healthcare. Imagine any of you spending more than a third of your income on healthcare. It would seriously jeopardize the fulfillment of other basic needs, especially if you're poor and you don't have much margin. Then impoverishing expenses are those expenses that take a household below the poverty line. Now, there are households that experience both. And as you can see, in the year 2000, about 1.5 million people had catastrophic, 1.7 had impoverishing, and another 500,000 had both. So all in all, almost 4 million households, these are not individuals, households affected by this. Now, what was the root of this problem? The root of this problem was what I will call in a moment the corporatist model. But this problem led to what we can think of as a paradox. We know that access to health services is one of the most effective means or mechanisms for reducing poverty. However, when a country doesn't cover everyone, then actually paying for care becomes a major source of impoverishment. And so the reform that was launched in 2000 was meant to solve this paradox and to make sure that access to healthcare was universal so that it could become a tool to reduce inequalities and combat poverty, rather than being a source of additional impoverishment for the population. And as I was saying, the root of this problem can be found in this segmented corporatist model, which I have tried to summarize in a very parsimonious way in this diagram. Every health system has to perform 3 fundamental functions. The first one is stewardship. Think of stewardship mostly as regulation. It's setting the rules, what drugs can be sold in a country and prescribed in a country, who can see patients, what do you require to open a hospital. That basic regulatory core, which is obviously essential for a health system. It also includes strategic visioning for the system, strategic stewardship of the system, setting a broad direction. And it also includes, very importantly, assessing, evaluating the performance of the system. That is stewardship. The second big function is financing. You actually need to mobilize and allocate financial resources so that the system runs. And the third one is the actual delivery of services, whether these are clinical services that are provided to an individual or public health services that are provided to entire communities. Now, the problem, there are many ways that health systems can fulfill these functions. The problem in a lot of Latin American countries was, and that includes Mexico, was that the health systems were designed to, in a way that separated or segregated different social groups. And in the case of Mexico, when the contemporary health system was designed in 1943, it made a fundamental distinction whether a person was salaried, had a salaried employment, for which in 1943, the Mexican Institute of Social Security was founded, later supplemented by ISSSTE, which is the equivalent institute for public sector workers. for bureaucrats and other public sector workers. The rest of the population who were not salaried, some of them were not poor, and the idea was that the private sector would take care of them, and some were poor, and for them, the Ministry of Health was created in the same year of 1943 with the idea of helping the poor receive the care that they couldn't do by themselves. The key issue of segregation is that each of these three subsystems were designed so that each of them performed all three functions, and that's why you see those vertical arrows. They had their own rules. For example, Social Security, like the Mexican Institute of Social Security, had its own rules, its own financing, mostly through a payroll tax paid by employers and employees, and it had its own delivery system, its own network of clinics and hospitals and salaried doctors and nurses and other health professionals, only for its own population. At the other extreme, the Ministry of Health had its own rules, its own financing, mostly through general taxes, and its own network of doctors, clinics, and salaried workers, health workers. And then in the middle was a private sector, which was highly unregulated. The financing was mostly out of pocket, very fragmented, and the delivery was also very heterogeneous. But the point here is that this system separated people according to their occupational position. And that, in political science, is the definition of corporatism. It's a system of interest representation where rights are allocated based on the occupational position of persons. And in this case, the big distinction was between the salaried and the non-salaried population. Now, this is the way the system was designed. This is not actually the way it worked. About 30% of people who had access, had the right to be taken care of in the Social Security institutions. Actually, they were so dissatisfied with the care that they would go to the private sector and even to the top hospitals of the Ministry of Health. Similarly, a lot of poor people use private services, and that contributes to their impoverishment. But the point in 2000 was that this corporate system had led, Mexico at that point had about 100 million people, and about half of them were insured, mostly by social insurance administered by the Social Security Institutes, and half of the people, about 50 million people, were uninsured. Of those, the vast majority were poor people. Okay, these were mostly, the largest group was peasants who don't have an employer, but you also had merchants, people owning their own stores, self-employed professionals like lawyers and accountants, even some physicians who worked on their own, who, because they didn't have an employer, they did not have social insurance. And private insurance in Mexico has always been very small. And because they were uninsured, these poor uninsured people, which were about 50 million people, that's what led to that level of catastrophic expenditures and impoverishing expenditures of about 4 million households. That was the most salient problem that we tried to solve. And this is the essence of what happened. We created a public insurance scheme. We call it the System of Social Protection in Health. This was legislated. It was a piece of legislation that was approved in the year 2003 and came into effect on January 1st, 2004. And it had an operational program called Seguro Popular, which literally, I'm sure many, if not most of you speak Spanish, but Seguro Popular means people's health insurance. It was meant and addressed to the poorest members of society. And therefore, it was very explicitly an instrument to close, to try to address or close the socioeconomic disparities in access to care, and through that means to be able to deal with the underlying major structural problem of Mexico, which is social inequality, broadly speaking. So as you see, the main purpose was to mobilize additional public resources to ensure that 500,000 with a public scheme. And from a legal point of view and an ethical point of view, the main objective was to change the nature of access to healthcare from being a benefit of employment to being a universal right, independent of the position of a person in the labor market. By the way, Obamacare, which was legislated about a decade afterwards, in 2009 and 2010, had the same idea. It was trying to decouple in the United States. The United States had something similar. Access to insurance was largely mediated by employment, the majority of insurance. And it tried to decouple that access to insurance from the employment status of people. This has been, China had a similar reform in about the same time. This was a global movement to decouple those two. So in the case of Mexico, in summary, the solution was a new public scheme for ensuring those that were excluded from the formal social security institutions because they did not have a salary job. The vast majority were peasants and impoverished urban dwellers. Now, again, I would urge you, if you are interested, there's a vast literature, including dozens of papers that I myself have written, but then many, many that have written by independent people like Professor Moreno and many others. So I'm really summarizing a very complex scheme in just the bottom line. The benefits were that it covered, and through an interesting financial scheme, it covered 290 interventions, basically everything that is delivered at the primary care level and in general hospitals. And then it had a separate fund, actuarially calculated, to be able to protect people from very high cost interventions. The first intervention that was covered here was universal treatment for AIDS patients, and then immediately followed for the most common cancers for children, eventually covered all cancers for children, breast and uterine cancer, and other cancers as well, but there was a focus on cancers that disproportionately affect children and women. There were other complex diseases that got covered through this fund, which was meant to grow progressively as more people got enrolled. Again, lots of, this is probably, as far as I know, the most widely evaluated program, health-related program anywhere in the world, because we wrote into the law the obligation to evaluate it periodically, and that included even a quasi-experimental randomized trial in the early stages of Seguro Popular, comparing randomly allocated and matched communities that had started already being enrolled in Seguro Popular and others that did not. And there's substantial evidence that these were the main effects. There was a substantial increase in public investment in health. Actually, the budget, as I will show in a moment, of the Ministry of Health quadrupled in real terms. A huge expansion of social protection coverage. I'll show also that in a minute. Increased financial protection, meaning a reduction of out-of-pocket payments and particularly of catastrophic expenditures for health by households, a reduction of households being impoverished by taking care of the health of a family member. There was a major supply side investment with a growth in clinics and hospitals, including high specialty hospitals, which were all concentrated in the three main cities, a regional system of high specialty hospitals. And then something very important, because this is what set the stage for what could have been the next step in the current administration, but was the step that was not taken, which was we had managed to create a unified financial scheme. And let me just tell you what I mean by that. By the year 2018, Mexico had now 3 public insurance schemes. IMSS, which is the Social Security Institute for the salaried workers in the private sector of the economy, salaried workers that work for private companies. ISSSTE, which is the Social Security Institute for people, salaried workers in the public sector of the economy, government and other public entities. And then Seguro Popular for the non-salaried population. Each of them, through successive reforms of the IMSS law the health law, and the ISTE law now had the same structure. Each of them, we managed to achieve a situation where for every person enrolled, independently of which of the three public schemes they were enrolled, the federal government from general revenues made exactly the same capitated payment. That was a huge progress because that didn't happen before. Before, all of those contributions went to social insurance and not to the uninsured population. So this was made common with the basic ethical principle that the lives of everyone are valued the same, and therefore public resources should be allocated equally. And then you had some minor contributions in the case of Seguro Popular from the beneficiaries. In the case of Seguro Popular, about 90% of the families were exempt because the law said that the poorest 20% of the population would be exempt from that. And because these were the poorest people, this was very small. And then you had a co-responsible contributor for the social insurance. This is the employer. That's the basis of social security financing. But in the case of Seguro Popular, by definition, there's no employer. So we had something called solidarity contribution with a mix of state level and federal contributions, depending on the state of the degree of development of the state. So this had basic redistribution objectives both among states, because states are highly unequal in their level of wealth. The south of Mexico is much poorer than the north, but also it had a huge redistribution component to the poorest families. And in fact, in some of the evaluations, Seguro Popular, along with the conditional cash transfer program, were found to be the most progressive policies in the government, meaning progressive in the sense that they would redistribute wealth or income, more specifically, from the richest to the poorest. So now there were also challenges. Seguro Popular was not perfect at all after it started being implemented in 2004. So after 14 years, any public policy has erosion. But also there was a problem of an increased demand. The population continued to grow. And more importantly, as Professor Angel knows, since she's an expert, it was aging very rapidly. And as populations age, the proportion of health problems from non-communicable chronic condition increases because those affect aged people disproportionately. There were serious problems of quality. Quality was heterogeneous. And there were a few isolated but very visible cases of corruption. They were truly isolated. And the problem was not Seguro Popular. The problem was corruption. There was no money for health before. Well, now that you had money for health, corrupt politicians took some of that money. So those challenges were real, and they were addressable. The point is that by 2018, we were one step away from universal health coverage. At that point, according to the intercensus estimates and the National Survey of Income and Expenditures of Households, about 100 million people had some form of insurance. Public insurance was Seguro Popular, and then social insurance, which are the social security agencies. I mentioned IMSS and ISTE. There's three smaller. These are for the armed forces and the oil company. But the bigger ones are IMSS and ISTE. Those had about 42 million. Seguro Popular by 2015, these are numbers from 2015, had 54 million persons enrolled. It was the largest health insurance scheme. Now, social insurance also provides other benefits that Seguro Popular doesn't cover, like pensions and others. But in terms of health benefits, it was the largest scheme. And then there were about 8 million people. As I mentioned, it's a small proportion, but half of them also had some public scheme, mostly social insurance. But they wanted to also have private insurance. In total, by that point, there were 117 million people in 2015. So Mexico had covered with some form of public insurance about 86% of the population. The conditions were ripe for taking the next step towards a truly universal system. But that's not what happened. And we started the administration with, I think, great optimism, because President Manuel Lopez Obrador, early in his administration, he started on December 1st, 2018, made these statements. He said, in 3 years, we will have a health service like that of Northern contracts, like the one in Denmark, in Sweden, like the one in Canada. That is my pledge. That, when I read that, I said, this is exactly the next step for Mexico. What these three countries have is these are public health systems, publicly funded, mostly publicly funded. They are highly decentralized systems, and they are pluralistic systems. When it comes to delivery, they have a mix of public providers and private nonprofit providers, which was exactly what we had proposed at the next step for Seguro Popular. And they are all have a single payer. So our idea and our proposal, was that those three funds that we had by 2050, well, actually, those three funds were already there by 2006, would merge into a single payer. You would still have, and you would break the barriers between the different provider or delivery organizations. So that was the pledge. What has actually happened it's now not been 3 years, but 5 years, is exactly that the country has moved in exactly the opposite direction. On January 1st, 2020, after a very, very rushed reform of the health law, with very poor analysis and not a lot of evaluation of the situation, Seguro Popular was dismantled and was substituted by something called Instituto de Salud para el Bienestar, or Health Institute for Wellbeing, which in turn, 2 years later, was, had failed, so it was now replaced with something called IMSS Bienestar. I'm not going to go into the details. We can talk about that in the Q&A, but both of those schemes propose a re-centralization, taking all of the infrastructure for delivery and putting it with a centralized agency, which is exactly the opposite of the examples the president said. It also reduced the health benefits. Seguro Popular already covered not just primary services, which is, the basic ambulatory services, not just secondary services in general hospitals, but also specialized. That's why we had the fund for catastrophic health expenditures. That fund was dismantled, and the funds that had been accumulated used for other things. So basically, the law that created INSABI only covers primary and secondary. So there was a real expropriation of social rights of people. There was a lot of weakening of stewardship, that first function I mentioned of. Again, the three countries that the president mentioned have strong stewardship. We've instead had done exactly the opposite. The area in charge of strategic planning was closed down. And then an autonomous regulatory agency that was established during my time, since I'm the first public health professional to be Minister of Health in Mexico, sort of FDA, with even some more regulatory powers than the FDA, has now been subordinated to the central bureaucracy of the Department of Health. It was a huge problem. If you follow what's happened with drug procurement, major scarcity of drugs and vaccines, the budget, instead of growing, which is, if you say you're aspiring to be like Denmark, you have to invest more in health, because those countries have about 10% of GDP spent in health. Instead of that, the budget was frozen. It has not grown. Even during the pandemic, it did not grow. There was an actual reduction in social protection. Studies have shown a lack of access and an increase in out-of-pocket expenditures and catastrophic. And then most seriously, deteriorating health conditions. Again, we don't have time to go through all the data, but there's a lot that's being published. But let me just give you three pretty basic information. In terms of coverage and budget for the Department of Health, the solid line is the budget. This is 2004 when the new law started. As you can see, the budget had been very flat. And because the law that creates Seguro Popular had a financial formula that stipulated an obligation from the government, an entitlement, to put a number, to a certain amount of dollars, a capitated payment for every person that had enrolled. So as enrollment grew, as you see in the green bars, the budget grew. It had an automatic budgeting mechanism. It grew to a peak of 2015. The last 3 years of the administration prior to the current one saw a decline in enrollment and a consequent decline in budget. but it was still way ahead of the historical averages. This is what's happened now with the reforms that started, terribly enough, on the exact time, the same day that the world knew about the new pathogen and the new disease called COVID-19. Remember, China declared on December 31st. That's why it's called COVID-19 and not COVID-20. If they had waited one more year, it would be called COVID-20. Well, the following day from the announcement, the new entity came into being, and it has seen a drop in beneficiaries. Now, these no longer, they canceled the formula. I called this in one of my articles a budgetary suicide for the Ministry of Health, because now there's no formula that pegs the number of people enrolled with the budget. So the budget has basically been frozen, even with the pandemic. This hasn't grown after the pandemic. The more important and dramatic thing is this one, and this is the one figure I want you to focus. This is life expectancy at birth, which is like the summary measure. And of course, between 2019 and 2021, it dropped by more than 4 years. Okay, or yeah, a little bit more than 4 years in life expectancy at birth. A huge, huge decline that brought Mexico to about the same level we had in 1991, which was 20.6, more or less the same level. Now, this happened everywhere in the world, not everywhere, but almost every country of the world, because of the pandemic. A lot of this was driven by the pandemic. But sadly, because the government had this massive change, I mean, one thing that could have happened was to delay the implementation of the new organization until after the pandemic, but they decided to continue implementing INSABI. So Mexico had one of the poor performances during the pandemic. So this happened everywhere, but this is a recent analysis. If you look at the number of years that each country lost in terms of progress, as you just saw, Mexico lost 30 years. It went back. In 2021, life expectancy was the same life expectancy as in 1991, 30 years later. And if you just look at Latin America, Mexico is in the company of Venezuela and Cuba as the three countries that had the largest regression, bringing their levels in 2021, in the case of Venezuela, 36 years to set the level that was there 36 years ago, in the case of Cuba, 38 years ago. Much, much worse than, basically all the other countries in the region. And this is just a reflection that Mexico, in terms of number of COVID deaths per 100,000, in terms of excess mortality, about 700,000 people in terms of excess mortality, had one of the worst performances for the pandemic. So instead, at that point, instead of moving forward, we went backwards to the old corporatist model, which was centralized, segmented, and poorly financed, instead of the public pluralistic model. So what we need, and I'm just going to mention this because we are out of time, we need a new generation of reforms. And the gist of it is, remember this graph where we had segregation of social groups that replicates and reproduces social inequality. We need to turn this around and organize the system by functions. This is what those countries, Denmark and Canada and the UK, most of the countries in Western Europe and Australia and New Zealand, this is the way they are organized. Stewardship is the main function of a Ministry of Health, and it's the same rules for everyone. There's a universal health fund, which is what we were ready. We had 3 funds. It would have been relatively straightforward to unify them, not easy, but straightforward. And then you have a delivery system that's pluralistic. You have public providers, and you also have private, especially private nonprofit. If you look at the UK, GPs, general practitioners, are not salaried employees of the government. They are private contractors. In their small clinics, they take care of people, but they are funded with public funds. People don't pay out of pocket. In Canada, Hospitals are private nonprofit entities, they're not part of the government, but they are funded publicly. What defines the public nature of a health system is how strong is your stewardship and the fact that financing is public, not private. People don't pay out of their pockets. If you have these two, you can have a pluralistic system where you give people a choice, provided that thanks to strong stewardship, everyone, every provider, whether it's a private or a public provider, it doesn't matter, has to follow the same rules that are defined by the stewardship function. And every provider is paid mostly through public funding. This is the model that's why I call it public pluralist model that had been promised, but instead we went backwards to this system that we had in the 1970s. But this is the way forward. To move there, we have to do a number of reforms. Those 5 reforms, and I'm really just going to mention them. The legal reform basically means that we need to eliminate a contradiction in the current constitution, because Article 4 recognizes healthcare as a social right. Article 123 declares it as a labor benefit. It's okay if it's a labor benefit, but it should be a social right which everyone exercises equally, irrespective of their position in the labor market. The financial reform is to increase allocation, at least to get to the Latin American average of 7% of GDP, which right now around 5%, and that includes public and private. And then you can read what there is. There's a single insurance fund, a general social contribution, a common package of health benefits, which is independent of who delivers them. And then as I said, a publicly funded universal health insurance fund. There's a need for a managerial reform. The system is poorly managed, as we saw during the pandemic. The essence here is to separate functions and then use certain instruments that we had actually started with the Seguro Popular, like a universal health ID and a unified reimbursement mechanism. And then we need a new delivery model that doesn't respond to things like pandemics once they happen, but that anticipates and is proactive in developing the necessary community-based interventions and addressing the social determinants of bad health, so that you're not just reacting to health problems when they appear, but you're proactively preventing. This is the only way to deal with the chronic non-communicable diseases that center around people, both patients and populations, that has a strong commitment to quality measures and monitors and guarantees quality. That's comprehensive, meaning it covers everything, not just primary and secondary services, but also specialty services. Does so, and also, by the way, it's comprehensive in the sense of covering health promotion, prevention, diagnosis, treatment, rehabilitation, and palliative care. It's continuous throughout the entire life cycle of people, pluralistic in the sense I mentioned, interconnected networks of providers, sustainable both in the financial sense and very importantly in the environmental sense, since health facilities are particularly polluting. Responsible meaning it is accountable and responds to people, and highly innovative. I think there's a number of technological platforms like electronic medical records, telemedicine, which the pandemic really underscored how useful it can be. The management of big data and artificial intelligence that is well deployed can greatly enhance the health systems of the future. And then we need a participatory reform. We saw during the pandemic the malicious effect of mis and disinformation. So people need to be informed, need to be educated. We need to counter misinformation. We need to strengthen the involvement of civil society organizations, not weaken them, as has been done during the current administration, and then be able to measure opinions and preferences of the patients and population. I propose that a next step, because there's been so much regression, and because there's a presidential election next year, I think now is the time to create an independent, non-partisan commission that really looks into what should be the future. How do we repair a lot of the harm that has happened? But more importantly, it's not to go back to the way things were before 2018. That was not optimal. It's to move us forward as we thought would have happened in the current administration, but has not happened. I think by the time of the next, if you have a truly pluralistic, for the next administration, if a truly pluralistic participatory process can be set in motion, whoever wins the election, there should be a consensus on how to move forward. There's many precedents of commissions like that. The most famous is the Beveridge Commission that assembled during World War II and gave way to the National Health Service in England, but the Romanov in Canada, the Lagos Commission here in Latin America, in Chile. And it should be, as I said, pluralistic with an independent president who talks not only about health, but has the ability to look at economic development, social inclusion, to reduce those inequalities and that have stemmed from the segmented nature of the current system and political stability. In summary, I think we owe to everyone who suffered so much during the pandemic, not just to go back to the old normal or even a new normal, but to really build a better normal. This is the only way that societies are going to recover from the collective trauma of, worldwide, about 20 million excess deaths, as by the WHO estimate, countries like Mexico, 700,000 excess deaths. That drop in life expectancy, we need to do something better than what was there before. Actually, I think there is agreement on the what. It's exactly what the current president said at the beginning of his administration. It's a health system similar to that of those countries, not identical. Mexico cannot adopt, but can adapt that model of a publicly funded, well-stewarded, pluralistic model. So it is easier when you agree and have consensus on the what. Now we need to agree on the how, and that's what I think is the next step for Mexico to move forward in its search for healthcare as a universal right that becomes one of the major instruments to fight poverty and reduce social inequalities. Thank you very much, and I am at your disposal to answer any questions you may have.
Thank you very much, Dr. Frenk. Well, this is the time to open the dialogue with the audience. But let me first mention that I'm glad to have two distinguished guests. Professor Jacqueline Angel, Professor of Public Affairs and Sociology, and a faculty affiliate at the Population Research Center and the LBJ School Center for Health and Social Policy at the University of Texas at Austin. Thank you, Jackie, for being here. And Dr. Sophie Morse, LBJ School graduate who recently defended her dissertation on violence against women in Mexico and the response of the public healthcare system. Welcome, Sophie.
Thank you so much.
And well, we are going to proceed like the other day. We are going to take sets of 3 questions and give the voice back to Dr. Frenk. And our time limit is like 40 minutes, okay? So just raise your hand if you want to participate, to give a comment or a question to Dr. Frenk. Gabriela.
Yes.
Well, this is not my area of specialty. Okay, let me try to approach you a little bit to get you closer. Well, I'm sorry, this is the best I can do.
Should I sit in the hot seat?
Okay. Adelante.
Okay. Thank you so much, Dr. Frenk. I'm so honored you came to visit our class, and to give this such valuable information. I didn't know all of that, and that is really, really important for me. But I have 2 major questions, and the first one is, what were the things wrong with Seguro Popular? Like, what were the deficiencies? Did it fail to reach certain people? Were there inequities, inequalities that weren't addressed? Because you say it was imperfect. So what was lacking? And second question is, you mentioned comprehensiveness in coverage in terms of health coverage and services, but what about services in remote regions? So comprehensive in providing clinics and hospitals to make it easy access for peasants and indigenous groups. That's it.
Okay, thank you very much. I see we have online Manuel Barragan.
Yes, thank you, Professor Moreno. Dr. Frenk, thank you so much for being here. This is quite an opportunity that we get as students from your presentation, so thank you. My question for you is, knowing what you know now about the implementation and results about of the Seguro Popular, what would you change to improve the quality of health services in Mexico? And do you think something similar can be done in the current administration to improve the quality of health delivered in the country? And that's it. Thank you.
Thank you. I see Adela raising her hand.
Yes, thank you, Dr. Frenk. This was very comprehensive and amazing synthesis of the past and present challenges of public health in Mexico. I have a question about the role of preventing medicine within a public health system. One of the arguments, I think, at the beginning of Obrador's administration was the fact that preventiveness was necessary to also tackle specific diseases that had to do with inequality, like diabetes or obesity, etc. So I just wanted to know what is the role of a holistic view of medicine, not only to combat illness, but to prevent illness, and what would be the role of the state in this, in this realm?
Thank you, Adela. So we have our first set of 3 questions. Dr. Frenk, go ahead.
Sure. First to Gabriela, I mentioned some of the deficiencies in the Seguro Popular. Basically, Mexico has a constitution that says that it is a federal republic, and the federal republic means that states have some functions. And the Constitution clearly says that healthcare is a concurrent function, like most federal systems, but that most of the primary and secondary levels, the basic clinics and the general hospitals, are a state responsibility. We designed Seguro Popular with that framework because, that is what the Constitution says. And I have to say that the main issue was that the implementation was heterogeneous among different states. In fact, most of the evaluations that have been done show that, in the states where you had a strong state-level secretary of health, which, by the way, the secretaries of health are appointed by the governors. It's not different than in the United States. In the past, in the 1970s, the people who had all of the healthcare was centralized by the federal government, and the people were appointed in Mexico City. So you had, people in Mexico City trying to figure out the drug supply in every remote little clinic around the country. It was totally centralized. In the 1980s, early 1980s, we started a process of decentralization that culminated in 1997. And now all of those responsibilities were transferred to the states with state secretaries appointed by the governor. So the main determinant of the variation in quality and other measures of performance was the quality of the team that was there. In those states that had a strong, technically competent, and politically savvy Secretary of Health, and there were many of those, Seguro Popular produced excellent results in those states where you had a weak secretary, including, the most famous case of corruption, which was in the state of Tabasco, which had previously been one of the best performing states. But subsequently, there was, the governor had appointed someone who was not really very strong, and the governor is now in jail because he embezzled some of the Seguro Popular funds, that governor. But that, to me, was the main issue. Now, the solution is not to go against the Constitution and re-centralize. Mexico has, about 128 million people now. It is impossible to run it as a centralized. The solution is to have more controls and more training, so that, and one thing we tried, but we were told it was unconstitutional, was to have governors nominate a series of candidates to be Secretary of Health, and then be able to rank them by their performance. That was not possible. What we do was to publish every year a scorecard and try to put political pressure on states that were really performing badly. But I think that is the main weakness. The other is, the second part of your question is very good. What happened with remote regions? When you saw that graph where in 2015 about 14% was still uncovered, there was a small fraction of those who were very rich people, but I frankly, I'm not very worried about them. They mostly fly to the United States to get healthcare. The vast majority of that 14% were people living in remote, hard to access areas, and that is a complex issue, because you can't have everything there. That is where application of technology like telehealth, which now was there before the pandemic. In fact, we started some telehealth projects during the time of Seguro Popular, exactly to try to reach those remote locations. But the pandemic greatly accelerated that process, as millions of people who couldn't go to facilities were using telehealth. We need to make serious investments to elevate the quality, to reduce the digital gap, and to build networks where people in remote areas can be seen by the top specialists, when obviously it is impossible financially to have a full complement of specialists in every one of the remote areas of Mexico. As you know, Mexico has the paradoxical coexistence of some of the largest urban concentrations in the world, along with a highly dispersed rural population. That's a major challenge. But I think it's one that can be addressed. You also mobilize community health workers, but not as isolated people, but connected to a network of services, so that when people need higher levels of care, they can do that. And you also mobilize indigenous practices, which is something we started when the Constitution was reformed during the period of time in 2000 to 2006, to recognize Mexico as a multi-ethnic society, and establish the requirement that complementary forms of healing were integrated within the health system. So those are all ways of addressing, but those were some of the main limitation of Seguro Popular was the greater heterogeneity in quality. And that leads me to Manuel's question. With knowing what we know now, I think we did create something called the National Crusade for Quality of Care. And for the first time, we were monitoring things like waiting times. So it was not just technical quality, there was some technical quality, but also interpersonal quality. If you make people wait, it's a sign of disrespect to people. But then we also had the more standard measures of hospital-acquired infections, proportion of patients who get readmitted, different measures of outcomes in terms of solving problems, coverage of some services which have improved, like vaccinations, all of that. And we did publish that annual report in a very graphic way. And that was actually, that report was always presented at something called the Citizens Health Forum with civil society as a way of putting pressure to states. But I think, and we did do quite a bit of training and created quality of care people. We created at the federal level an undersecretary for quality and innovation, and had Dr. Enrique Ruelas, who's like the world expert on quality. But to bring that to the actual front lines, not at the level of the federal ministry or the state level departments, but to take it to the front lines within the community health centers, the clinics, the hospitals, and make quality and the culture of quality really be part of the day-to-day operations. And that, today what I would recommend going forward is not the extremes of total decentralization as happened in '97, but not the re-centralization that's being proposed now, which is not functional, but something in between that actually establishes clear criteria for hiring everyone, a very vigorous training program for both health professionals that are on the front lines, but also managers, including the state secretaries of health, and better monitoring and accountability systems. And then lastly, on Adela Pineda's question, absolutely, prevention, the first element of the new delivery model that I mentioned is to be anticipatory and proactive. No health system, not even in the wealthiest countries, can deal with the growth in chronic diseases that accompanies both, the evolution of the social determinants of health in our urban societies and the aging of populations, plus, the problems of being in a highly interconnected world, like we just saw with the pandemic. No health system can only be responding. It's unsustainable. We need to embrace not just solving problems when they happen, but anticipating. And there's this concept of salutogenesis, the idea of creating environments, both natural, physical, and social environments that promote health, to deal with the largest risk factors like lack of exercise, smoking, and abuse of other drugs, all the conditionals of violence, including intimate partner violence and other forms of violence against women and children. I mean, if we don't act on those upstream determinants, no health system just focusing on the downstream consequences can actually be sustainable. So that's actually the number one piece. It is true that in the early statements, that was place of the current administration, but the assessments of the National Nutrition Survey don't show much progress, for example, with things like obesity. And in fact, during the pandemic, ironically, one of the things that was done was to blame people who were dying of COVID because they had risk factors, which I don't think is the right way to approach those risk factors, blaming those who suffered it. The role of the state, you ask, is absolutely critical. A lot of those programs are public goods. Some of those environmental interventions, like safe water and clean water and sanitation, like clean air, those are quintessential public goods that can only be delivered with a very important state role in that. But even elements of health promotion that maybe more at the municipal or local level, like having green spaces, like protecting women who live in violent households. All of those are programs that require state participation, even as strong civil society organizations partner with the state. But these are, this is the core of public health. and it does require that kind of societal involvement.
Thank you very much. See here, Paloma. Go ahead, Paloma.
Dr. Frenk, could you please tell us what do you think are the political and cultural conditions that influenced the adoption of laws to depenalize abortion in Mexico? I think that was 2 years ago. And do you think that these laws could be affected by the recent push in the US to reduce reproductive rights?
Thank you, Paloma. I see Celeste.
Hi, Dr. Frenk. Thank you for coming. My question is, do you think Mexico is ready for universal healthcare? And what are the prospects for achieving a universal healthcare system in Mexico? And what role do you see for government policy and private sector investment in this sector?
Thank you, Celeste. So,
hi, Dr. Frenk. It's a pleasure to be here. And I just, in defending my dissertation, talked about the leadership that you provided on sexual and reproductive health as the Secretary of Health, which has influenced the response to violence. So thank you so much. So the commission that you propose seems to me to be kind of a return to this notion of putting non-political experts or technocrats into a role of leadership and kind of stewardship that the current president has been so opposed to, right? And I think it's quite intriguing, but with the backdrop of kind of low trust in institutions in Mexico broadly, and then power dynamics that in the medical system between kind of patients and providers, including obstetric violence, but also just kind of basic disrespect. I'm wondering, kind of to complement this notion of this high-level commission, what some of the best mechanisms to involve civil society in this health reform might be. Because I spent a year in Mexico doing field work, and I think part of the issue is that citizens and NGOs don't necessarily feel like they're given a voice in many of these kind of top level political decisions and policy decisions. So I'm just wondering what some of the ways that they could be involved would be moving forward. Thank you.
thank you, Sophie. Dr. Frenk.
Well, these are all excellent. On Paloma Diaz's question, yeah, I mean, the political circumstances it did start in Mexico City, which has had I think in some of policies like access to safe abortion with universal access to safe abortion. It started in Mexico City and has gradually spread. I think that's been an element I link it to the last comment. Civil society has been absolutely critical. Mexico does have, there is a strong debate. It's not that there's unanimity around the abortion question. In fact, surveys show that more or less half of people oppose or would like, or at least would have some restrictions, and the other half are in favor of removing all restrictions and making this a decision of the woman involved. I don't expect that the decisions of the Supreme Court in the United States will greatly change that. We've made a lot of progress. I did have during my time in office to deal with a number of controversies, especially because the government I was serving in, the party that was then in power, had a more conservative wing of the government that opposed a lot of these measures, including emergency contraception, which was a big measure that we adopted. And the way they were opposing that was equating that with abortion, which was technically incorrect, but also, it tried to mobilize that more polarized issue. I think I have to tell you, having been in my position as Secretary of Health, having had to confront the Secretary of the Interior, which is the most powerful position in the cabinet, and persuading the president at that point to support our initiative based on all the evidence I brought, that actually access to emergency contraception would reduce abortion rates. Having won that battle, I have to tell you that this was probably the most popular measure that that government took. There's strong popular support to the notion. I'm not saying it's universal, and I'm not in any way minimizing the presence of highly conservative groups and organizations, including, of course, this is a country where a majority is Catholic. So I'm not minimizing that, and obviously I have total respect for anyone's beliefs in any of these issues. But the fact is that Mexico has managed to implement and adopt policies that are supportive of the women's right to choose. And I hope I'm not too optimistic. I don't think that it's going to, that is at risk of regressing in the near future. But it's a fight that needs to continue to be engaged in, and it's mostly by first of all an ethical discussion, and then also an evidence-based discussion, that actually all of these restrictions end up backfiring and not just costing lives of women, but they actually don't work to stop. What works is to provide safe abortion and provide all the measures that prevent the need for an abortion, like emergency contraception and other forms of access to contraception. So something, a very critical piece, and certainly for me, it was a big part of my of what I did during my period in the government. To Celeste's question, I wasn't able to hear exactly everything you said, but I believe your question was whether Mexico is ready for universal health coverage. I think it is. I think, I mean, we've now lost ground, but certainly in 2018, Mexico was ready to take that step. The main obstacle here is that in corporativism, each organization, you have this in corporativist systems, both management and unions take control of public institutions. And the challenge is to break that stronghold of, for example, IMSS. I think the key here is to open the Instituto Mexicano de Seguro Social, IMSS, which is the largest and most important organization, and to allow people to be seen at IMSS who are not the beneficiaries, to open and desegregate the delivery of services. Now, that's a very difficult thing to do because there's a lot of vested interest in keeping these closed, segregated systems. In our reform in 2000, actually the first option was to universalize IMSS, a little bit like the Costa Ricans did in the 1970s. They took their social security, they extended it to the non-salaried and had the government pay the premium. Because, obviously these people who are not employed, you don't have the employee contributions, which is a core part of the funding of social insurance. So the government took care of those contributions and they unified the system. That was actually what we first proposed, and we found strong opposition, not just from the union, but also from the Director General of IMSS, which is characteristic of these corporate structures. So that's when we said that we couldn't have the poor non-salary people wait forever without an insurance scheme. That's how we created Seguro Popular as the public insurance scheme for the non-salary population. But I always said this was a midterm reform that then needed to lead to a true unification where you had a single payer, and when people could use any facility that was properly accredited. Didn't matter who managed that. Because just think about what happens today in Mexico. If you are a citizen of Mexico, you have all your rights, except you cannot go and be seen in a public clinic or public hospital. These are public clinics. They are funded publicly that are managed by IMSS or e-state. You can't. Your condition as a citizen is not enough for you to be taken care of, except in emergencies, in a public entity like the clinics at hospitals of IMSS and e-state. That is, I have called this a medical apartheid. The separation of people is not according to race, like in the South African apartheid, but it is according to labor status. If you are a salaried worker, you cannot exercise the same rights. You exercise more rights than if you are a non-salaried worker. That has to finish. That's what Seguro Popular was, a big step in that direction, but not the final step. So we need to take that final step. And I think Mexico was ready then. And of course, this can only be driven with a lot of public leadership, government leadership. The sad thing in this case of what's happened with this administration is that we couldn't do it in 2000 because the president didn't have a majority in the Congress. And the same thing happened with the two subsequent administrations. The current administration had a majority in both houses of the Congress. They could have done the legal changes to take Mexico to a health system like that in Denmark, or in the examples the president did. And for reasons I don't have insight into, the actual implementation of laws and programs went exactly in the opposite direction. There was one reality of what the president articulated as the strategic vision and what actually happened. But that vision was the right one, and they did have the political balance to have actually pushed the reforms to build a system like Denmark. But chose to go in the opposite direction. I think that's what I'm trying to do. And I will go then to the final point on the final question of the commission. I'm not suggesting that it be technocrats or non-political entities. It actually should have representatives, and it should have a big role for for civil society. It should have the trade unions, which are likely to oppose a lot of these reforms. You need to bring them to the table. It should have the associations of employers as well, the private sector. And it should be a non-partisan, but that doesn't mean that people who participate in the commission don't belong to a party. So it is actually meant to be a pluralistic. When I say non-partisan, I didn't mean that it's apolitical. I meant that it is not managed only by one of the parties. And I particularly see a strong role for civil society. We were very deliberate in involving civil society. They were our allies in this reform. I mentioned that the first disease that was covered for this fund for catastrophic health expenditures was universal treatment for HIV/AIDS. And that is a part of civil society that's highly organized in Mexico, and they were extremely helpful. They worked hand in hand with the government to promote the passage of the law because they saw the benefits. And then we created something called the Annual Citizens Report. This was not a bureaucratic report. We selected, in agreement with the states, I think it was 45 indicators, and with 2 pages per indicator, very graphic, a small text explaining, we did a benchmarking of states, ranking states on each of the 47, and that was released in something called the Health Citizens Forum. I don't know if in your trips to Mexico, in your research, you found them, but these were publications that were published from 2003 to all the way to 2006. Every year we did the Citizens Forum, and I think it continued a little bit into the next administration, but I'm not sure what they did with that. And in the Citizens Forum, we had all the civil society organizations, and they could see how the different states fared in all of those indicators. And that, to me, was a very useful tool to put pressure on governors to actually improve their performance, because no governor wanted to be at the bottom of those rankings that we did. So anyway, I hope I addressed all the different points.
Yeah, thank you. Do we still have some time for maybe very, very brief questions?
Sure.
Azim?
You mentioned universal healthcare a fair amount. When we talk about universal healthcare and we talk about 100% coverage, you said Mexico could get a system similar to the Nordic countries. Mexico has a tax rate of about 15 to 30%, and those countries have a tax rate of like 50%. Do you think that you would be able to accomplish this reform without raising taxes like super substantially?
All right, thank you. Jackie?
Yes, thank you so much, Dr. Frenk, for joining us today. It's such a pleasure. Interested in your opinion about what are the incentives of President AMLO in adopting this commission, especially given his pension reform attention that he's spending a lot of time on for older adults at the expense of healthcare reform. And also, second question is related to who would serve, or who would you recommend specifically to serve on this prestigious commission? And have you thought about joining that commission yourself?
Very good questions. May I have my own chance? When the INSABI idea started, Dr. Frenk, some states in Mexico, there were 9 or 10 states that refused to voluntarily join the new agreement. Jalisco, being one of them. And in the end, Jalisco decided not to join the INSABI, but they signed an agreement. Jalisco would continue receiving federal funds. Of course, as you mentioned, those would be not subject to a formula. There was a risk of discretionary allocation. But what could you say about the states that in the end decided not to join to INSABI? Do you think they are making good progresses in their own healthcare systems? Thank you.
Sure. Well, those are all excellent points. To the first question, Alan, I will leave you. I sent Professor Moreno the PowerPoint because I went rather quickly through the last slides. But in the financial reform, what we suggest is the introduction of what we call a generalized social contribution. Now, that is a tax, but we need to study which tax would be the best. You are absolutely right. You cannot fund this without additional taxation. And the reason, and you know, what's mentioned in that slide, and which, by the way, is taken from an article I wrote in the magazine Nexus, which is a cultural magazine, not a specialized journal, on September 1st of 2021, when a new Congress was installed. And that's where we suggested this idea of the commission, hoping that the new Congress would take up the idea. They didn't take up the idea, but the article in Nexus, it does explain much more of what the proposal is. But you'll get a better sense looking with more calm at the slides. So the idea of the generalized social contribution, it can be a mix of income or consumption taxes. The key here is it's got to be the one that, not theoretically, but in terms of how it's actually implemented in Mexico, is the least regressive. You know, if we were a European country with the type of taxation system, you would probably base this on an income tax, on the income tax. But in Mexico, with the levels of evasion that you have for income tax, you probably need to tax consumption. And the question is, how do you do that in a way that's the least regressive one. And you obviously do that by exempting, for example, food, as it is right now, and then some other items that are disproportionately consumed by poor households. But the answer to your question is you need to increase the taxation. Now, having said that, there's a lot of waste in the system, and there's a lot of space for allocational, for technical efficiency, for the way you spend whatever you are allocated. We could also be better in allocational efficiency, which leads me to Jackie's excellent question. Yeah, there's been while health has been frozen, basically, what you have seen is this huge expansion in direct cash transfers. And unfortunately, this is one aspect where Mexico has really gone backwards, because there was all these mechanisms that were used in the past to avoid electoral uses of direct cash transfers. And part of that is this universal pension, which, the data show that with the previous conditional cash transfers, they were much more targeted to the poorest. You actually were getting much better results in terms of equity. I think we should aim for universality, but I think when your starting point is the level of inequality we have, to be giving, whatever the amount is every month to upper middle class people, although I like the principle of universality, the principle I like better is what someone has called progressive universality. And progressive universality means that you start by targeting the poorest people, like the previous conditional cash transfers did, and you gradually increase those so that they truly cover everyone. With pensions, there are other forms of transfer to young people and others, but with pensions, they went directly to the universal stage. And the result of that, in some analysis I've seen, is that you're now having, if you take the bulk of the transfers, it's mostly the top quintile of the income distribution that's receiving actually the largest transfers from the government. And the bottom ones are actually receiving less than before the current government. I'm sure you're familiar with this analysis. The incentive, though, to me is very clear. We've gone back to the old times of the pre-democracy times, where everything was the magnanimous discretion of the big charismatic leader called the president of the country. And in the times of democracy, and even building before the year 2000, a number of mechanisms, actually in the previous administration, the one that was headed by Dr. Cedillo, where the conditional transfers were created, there was a lot of legislation to avoid electoral uses and personal uses by the president to promote himself. Those have all been thrown out the window. I think that's the basic incentives. As to the commission, I don't have specific ideas. Again, the slides do talk about the type of people who would be there. But I think there's some very competent leaders of civil society with a broad view of health. I don't think this commission should be focusing on it should have a sound technical base, but you need mostly a convener that can bring people to the table and create, someone like Beveridge or others who were not directly in a political position, but had a very high level of reputation. It's not going to be easy to do this, and the fact of the matter is, we had hoped that the new Congress that was installed in 2021 would do it, but they have not done it. But I think now is the window to do it. And then lastly, with Carlos, a number of states refused to be part of that. It was mostly states governed by the opposition. INSABI was subsequently morphed into IMSS Bienestar, now using IMSS for the administrative capabilities. It is the ultimate expression of medical apartheid, the fact that the same institute manages a separate subsystem within the institute for workers with salary jobs and their families, and for families that are not part of that don't earn their income in a salaried manner. Who are not all of them are informal, by the way. That's a misnomer. And you have two separate set of clinics, two separate programs. That, I think, is the ultimate expression of corporativism. I would strongly support what we had proposed initially if all of that would converge into a model like Costa Rica. In fact, Costa Rica, more than Denmark, is a much more feasible model for Mexico, to be honest. And that would be highly feasible if we could deal with the corporativist interest. Your point is excellent. We do have a natural experiment, and I hope that it will be possible with scholars like yourself and others to evaluate in a comparative fashion what's happening with the states that don't participate in the new scheme and states that do, and let that evidence be part of the information we need to move forward. There's a lot of reconstruction to do in Mexico, and I think after these years, we need to have a clear sense of where we want to move. I do think there's that vision of moving towards a system, that is what I have called a public pluralistic system, which is the examples that the president gave, but it's also Costa Rica. That is a possible pathway for Mexico. And having the information on what happened in this period of very chaotic health policy, compounded by a pandemic, highly compounded by a pandemic, we need to learn the lessons. I always say the least we owe to the 700,000 who lost their lives and the millions more who lost their livelihoods is to actually build a better health system coming out of the pandemic.
Thank you, Dr. Frenk.
Thank you.
So if you agree, I will share the presentation with the audience later on. And
Sure.
again, thank you for being with us today.
Thank you for the invitation and good luck with everything else you have. Goodbye.
Thank you.
And Carlos, would you allow me to make one final announcement to your class? Very short, we have the visit of the Ambassador Marta Barcena, former ambassador of Mexico, who will speak on April 5th about the US-Mexico relations. It will be in our building next door in Lilas. We hope that all of you can go. Thank you.
Thank you, Paloma.